We have a 74-year-old gentleman with a history of cerebellar hemorrhage and other multiple medical comorbidities. He presented with acute severe pancreatitis in August this year with associated organ failure. At the time, the CT showed pancreatic necrosis at the body and the tail of pancreas. The condition resolved on conservative management, but this time he's readmitted for fever and also abdominal pain. Blood test showed leukocytosis with white cell of 18. Emergency CT showed there's a 16 times 13 times 6 centimeter collection with gas locules at the pancreatic body and tail, likely represent infected pancreatic ward of necrosis. This is the CT scan showing the gas locules within the large ward of necrosis over the left upper quadrant of the abdomen. Today we're going to perform ERCP plus EUS-guided drainage of the collection.
Yes. As case presented, this is 74-year-old gentleman actually have a lot of comorbidity and developed rather severe pancreatitis 4 months back, and they did conservative management. And most of the pancreatitis, if it is recovered well, generally does not develop again, but in this case 4 months later, developed pancreatitis again. When they checked the CT scan, we can appreciate large cysts near the tail of the pancreas. But if you look at the pancreatic CT carefully, not just the pseudocyst, world of necrosis, in the body of the pancreas, there was some small cystic area. So we were focused on that, and we suspected whether there is any persistent pancreatic juice leakage in the body of the pancreas. So instead of doing EUS-guided cyst drainage, we first started ERCP.
Okay.
And this is, can you see the ERCP image now?
Yes, we have a pancreatogram. Can you tell us more about this pancreatogram?
Also, can you see endoscopic image now?
Let's see. Okay, we have
endoscopic image. Yes. We started to do cannulation from major papilla here. This is major papilla.
Okay.
And we did a bit of sphincterotomy because we were able to do bile duct cannulation, but difficult to do pancreatic duct cannulation on this case. So repeated attempt actually failed. So we went up high to the minor papilla here, but the minor papilla was very much patulous. So we did cannulation through the minor papilla. And we checked pancreatogram here. Can you see the pancreatogram now?
Yes.
If you see the pancreatogram, the dorsal pancreatic duct is very much prominent, and the large caliber is connected to the minor papilla. Generally, dorsal duct actually connected to the ventral duct, and the ventral part generally becomes the major pancreatic flow, but in this case, the major flow is coming to the minor duct. And also, we can see pancreatic juice leakage. We can see contrast leakage in the body portion of the pancreas. Can you appreciate some cystic collection of the contrast in the mid portion of the pancreatic duct?
Yes. Can we have the fluoroscopy to be the bigger image? Yes.
Yeah.
Yes.
This is already kept with. So you can appreciate the contrast leakage from the mid portion of the pancreatic duct. So I did already inserted pancreatic stent across this leakage site. And if you see the fluoroscopy now, this is fluoroscopy image. Now you can appreciate pancreatic stent.
Yes.
Is already in the main pancreatic duct, but the entry site is a minor papilla. If you see the, can you see the endoscopic image?
Yes.
This is a pancreatic stent placed through the minor papilla.
Yes.
So this stent may function to prevent the persistent pancreatic juice leakage into the peripancreatic area. So this is the first step on this case.
Yes.
Then I will remove the scope and change the scope to echoendoscope and try to see the cyst world of necrosis in the tail of the pancreas. Yes, yes. Now I changed my scope through to echo endoscope. Now we are looking at the tail side of the pancreas, but it's difficult to appreciate the normal anatomy in this case because of huge cystic wall of necrosis. Can you see the hypoechoic lesion around this area? The shape is not very, round or elliptoid. A bit, the margin is a bit irregular. So if you look at, the shape of this lesion, I think there is some fluid material, but mostly some debris-like lesions are there. And also, when you see the CT scan on this case, there are a lot of air bubbles inside, which means there can be some communicating fistula between cystic lesion and some area of the bowel, maybe small bowel. Sometimes it can form the colonic fistula, but I don't know which area is the culprit area.
Right.
Or sometimes without fistula, if there is any infection by gas-forming organism, then we can see some gas bubble inside this necrotic area.
Yes.
Yeah, I think this area is the area, but it does not look like a clear fluid.
Right. Looks like there's some echogenicity with some debris.
Looks like some there already has been some organization on this area. And we can make a puncture on this area, but I'm not sure whether will it be drained well or not. On this case, probably the drainage will not be very good.
I see.
If you look at the thickness between the gastric wall and this necrotic area, this area is very thick.
How thick is
this area is around 8 millimeter, and can we do FNA on this lesion and try to aspirate something and send it for the microbiologic studies, culture of the organisms?
Yes.
I think we can do that, but I'm not sure whether it is a good idea to insert a stent to drain this area. I don't think it will be drained very well. What is the panel's opinion on this case?
Well,
any suggestion?
Yeah.
I agree with Dong-Wan, because the liquid component is actually not very big, and there's the solid component, also the thickness of the intervening tissue. So maybe you just get the microbiological study done.
Okay. Then we are going to insert a 19 gauge needle to aspirate some material. If you use a very fine needle,
so
we are going to use a 19 gauge echo tip needle. It has the very good visibility of the tip, and the size is big. So if you use a 22 or 25 gauge needle, I think we probably, on this case, we won't get much amount of cystic material inside the cyst. Now I locate the tip of this 19 gauge needle on the right side of the top. I'm going to do a puncture of this area, but generally before starting puncture, we use Doppler to check whether there is any large, big intervening vessel. It's going to be possible to puncture using probably this angle. Needle tip is here. Okay. I will make a puncture on this side. If the wall is thick, I may feel some resistance, so I'm using the safety bar here.
Okay.
Can you zoom on this, cameraman, zoom on this? And I think I will use the safety bar.
Okay.
Not to puncture the distal part.
Okay.
I think the needle probably went inside. Can you see it? Yes. The needle tip is inside.
Yeah, saw the needle tip there.
Yes. Remove the stylet.
So what is your plan? Are you just going to take some volume out, or are you going to drain most of it out?
아니요, aspiration. Yeah. Firstly, I want to check whether this content is purely fluid or not, or if something is aspirated, I want to see the color, and also if we can get some fluid, then we can send it for microbiologic study. This patient actually had infection, and this is infected peripancreatic necrosis. Although there is some formation of wall, I think this is still this patient have higher risk of developing sepsis and also a lot of problems.
Right.
I think we cannot get, can you see it? We probably need more pressure. Okay, now I'm going to apply about 30, 20 more negative pressure to check whether there is any material coming. And I will try to cover several areas by moving the needle tip back and forth.
Okay. I see the needle tip inside.
But I'm moving the needle tip into several areas, but nothing actually comes out.
This is better.
Okay. I try to locate the needle tip into several different areas of the cystic lesion.
Okay.
And finally, I was able to get this kind of a very thick infected material.
Can you zoom in and get a look of that?
Can you see it now, cameraman?
Specimen? Can we zoom in to the close in to the
Cameraman, can you show it?
Yes. Can we get a closer look of that?
Yeah.
Okay. Looks.
Very infected material.
Yes.
And a bit of blood is mixed, and also pus also is mixed. We are going to insert guide wire into the cystic cavity.
Okay.
And 뼈링이 생겨요. 그렇죠. Okay. Okay. I think if it is loculated lesion, it's better to have 2 or 3 loops inside the cystic cavity. But this lesion is very huge, and it's going to be difficult to make a round-shaped or elliptic-shaped roof. So I'm going to push the guide wire like this, and then remove the needle. And then I will use cystotome to dilate the puncture site. After that, I'm going to insert the lumen opposing stent. There are 2 different types of lumen opposing stent, Axios stent and Nagi stent. Nagi is made from a Korean company, Taewoong company. But this time, Nagi stent is available, so we are going to insert the stent into this area. Okay?
So what size of a cystotome you're going to use?
6 French. Yeah.
Okay. Do you always use a cystotome, or do you use a ERCP
in our
cannula?
center, cystotome is not available. I'm sorry. Only during live demonstration I use cystotome. I find it's very useful, helpful, but they do not. We do not have it.
I think in this case maybe it might be more useful because of the very thick wall.
Yes.
Yeah. So that's why we chose it.
Yes.
That's a very good point, because I think a lot of times the challenge is maintaining that wire access and be able to pass the cannula, the dilating catheter. But with this thickened wall, I think that will be a challenge. Yeah.
Now the cystotome is touching the gastric wall.
Okay.
But before burning,
can we have
we
the
need to
X-ray also a little bigger also? Yeah, so we want to see the cystotome. Okay.
And also we are trying to check whether there is a big intervening vessel.
Okay.
I think there is no. So I'm going to use cystotome to burn this wall out. So I want to burn it. Okay. I think we already went inside. Huh? Just a moment. Cystotome already went inside.
Yes.
Yeah, so, but generally, before insertion of the stent, push the guide wire in. While the assisting nurse inserting the guide wire, I pull the cystotome out and try to insert cystotome one more time. 가이드 와이어 빼고 들어가 볼게요. Because this is just in case. Sometimes, even though cystotome or microknife went inside, when you try to insert the stent, sometimes it can make some problem. So to check it, to prevent it, I am double checking the axis and the entry point. I think it's okay now. So we are going to push the guide wire in, and now I am removing the cystotome out, and we are going to introduce Nagi stent through this entry point. Okay, slowly. It is important to keep the coordinated movement during this whole procedure.
And now
Okay.
I see that not many loops of the guide wire is in the lesion. So do you have a preference of putting more loops in, or do you think this is pretty reasonable?
If the cyst size is small and it has round shape,
Yes.
I try to make two or three roofs. But this is very large cyst, and there are a lot of debris, so it's going to be difficult to make a roof inside.
Yes.
So I think we still have enough length inside the cyst.
Yes.
Okay. This is a Taewoong Nagi stent. It has a flared end. This flared end can prevent inward migration or outward migration. And it has diameter of 12 millimeter. So after deployment of this stent, we can introduce small caliber regular EGD endoscope through this stent, so we can go inside the cystic cavity to do some necrosectomy. Okay. This is 025 VG guide wire.
Okay.
VG2 guide wire.
I see.
The thickness is small, but it has stiffness like 035 guide wire. This is one of the beauty using VG-guided system. It is from Olympus. 잠깐만, 이 부분이 잘 안 들어갈 수가 있어서 이게 굉장히 조심해야 되더라고. Okay, we are introducing the stent introducer into the cystic cavity.
Sure.
Yes, this one is a fluoroscopic image. I used the 4 millimeter hurricane balloon to dilate the track, and then I inserted Nagi stent into the cystic cavity now.
Okay.
This is very tricky and the important part. The distal end is already inside the cystic cavity, and when we start to deploy, we are going to use 3 different eyes. One is fluoroscopic eye, second one is EUS, third one is endoscopic eye. Endoscopic one at the last moment. I want to start deploying the distal part first using fluoroscopic image. Can you deploy it slowly? Okay. 어떤 거? 자, 밀고 살짝 열고 distal만. We are going to deploy the distal part. Yeah. Can you see the
Yes.
distal flange is opening now?
Yes.
Yeah, here we need to see both EUS and also fluoroscopic images.
Yes.
If you see the EUS images, we can see the distal part is on around here.
Yes.
Just a moment. Okay. But before deploying, I also wanna see the endoscopic view. Here is endoscopic view. I want to make some distance between the gastric wall and now we can see the stent deployment system.
Yes.
Suction is not working. Suction is not working. Yeah. Okay, we can do water immersion technique. Okay, but not working. Okay. deploy. Fluoro, yes. Now, here, stop. You can catch the fluoroscopic image now. I'm sure that the proximal part is already inside, but we need to locate the distal part is inside. Locate the proximal part of the stent outside of the gastric cavity. So we must make some distance before full deployment. Okay. Now we can 여기서 릴리즈를 조금씩 해봅시다. 예, 자, 릴리즈. 예, 열어요. 더 밀고, we are deploying. 더 밀고, 풀백. 예, 더 밀고, 예, 더 밀고. Now
can we see the endoscopy view?
Yeah, bigger endoscopy view.
Let's show the endoluminal view. Okay, very nice.
Yes.
Very nice.
We can see a lot of pus material coming
Yes.
from the cystic cavity.
Yes.
Yes.
Can we have a big endoscopy view? So, yes.
Now-
Very nice.
From here, if you want to insert like a nasobiliary drain tube, we can use this guide wire
Yes.
to insert that, and you can do some irrigation. Do you
Yes.
want it or not?
I think that probably would be a good idea too.
Okay.
Yes.
Then we are going to remove the stent introducer system here,
Yes.
and then we are going to insert the nasocystic
Wow.
drain tube.
Do you think there's a need to
Oh,
dilate the
Yeah, this is definitely draining well here. We see
just a moment. Yes.
copious material coming out.
There is a suggestion. We can dilate the puncture site, the stent, to get a wider view. But as time goes, I think this will become bigger. We are not planning to do necrosectomy today. So, yeah. There is a lot of material coming.
Yes.
Now we remove the stent introduction system completely, but I still keep the guide wire inside the cystic cavity, and going to use a little thick nasocystic drain tube. Is it 7 French? 6.5 French. Here we have also 8 French or yeah.
it will come up.
I know in some centers they try to in some centers through this tube they use hydrogen peroxide
Yes.
to liquefy the debris and wash out the debris. Now my drain tube is going inside. Okay. A bigger fluoro. We want to see the wider area.
Yes.
I think the drain tube is already went inside the cystic cavity. Bigger one, right side.
Can we zoom out to
Zoom
see more view of the?
Yeah. Yes.
Okay. Zoom out one more, please.
Yes. It already made one coil, so I think this is good enough. I'm gonna remove the guide wire and also scope. Here, this also needs coordinated movement. Yes, slowly. Okay. Yes. Okay. In our
we should
hospital,
take this picture
fluoroscopists
here.
do this.
We
but
should capture your picture here. So,
okay.
yeah, very nice.
Okay.
So, thank you, Dong-Wan. It's very nice.